Welcome to AETCM, the Emergency Medicine Channel. As a part of EM Rapid 2024, today the topic is Vasopresors and Inotropes. Coming to Vasopresors, they are potent pharmacological agents used to increase the blood pressure and mapped by vasoconstriction, used in persistent hypotension and tissue hypoperfusion when volume resuscitation has failed. Vasopressors differ from inotropes, which increases cardiac contractility. However, many drugs both vasopressors and inotrope properties. Coming to first vasopressor, it is dopamine. It is an endogenous catecholamine and a metabolic precursor of norepinephrine and epinephrine. Dopamine produces a variety of dose-dependent actions. It acts on dopaminergic alpha-1, beta-1, and beta-2 receptors in dose-dependent fashion. Into dopamine action, intermediate dose, that is 5 to 10 microgram per kg per minute. Action on beta-1 and beta-2 receptors. In beta-1 and beta-2 receptor action causes increases the myocardial contractility, heart rate, cardiac output, increase the renal blood flow along with peripheral vasodilation. High dose, which is more than 10 microgram per kg per minute, action is on alpha-1 receptors, leading to vasoconstriction and increasing BP. Low dose, that is 1 to 5 microgram per kg per minute, dopamine is no longer recommended for renal protection. To the indications, one in hypertension or shock. First one, cardiac shock. Dopamine is not the preferred initial agent in cardiac shock. Consider other inotropic or vasopressors option. Option with use of dopamine is used to causes increased arrhythmias. Coming to the dosage, in continuous IV infusion, usual dose ranging from 0.5 to 20 microgram per kg per minute and titrate based upon the clinical endpoint. Coming to septic shock, another vasodilatory shock, not recommended for septic shock except as an alternative to norepinephrine in patients with bradycardia who have low risk of tachyarrhythmias. Compared to norepinephrine, dopamine is associated with increased risk of tachyarrhythmias and potentially worse outcomes. In general, maintain a goal mean arterial pressure. Consider use if patient is in shock or has hyperperfusion during or after fluid resuscitation. Continuous IV dosage is initial 2 to 5 microgram per kg per minute and titrate get a goal map up to a dose of 20 microgram per kg per minute. Dopamine usage in post-cardiac arrest shock. Typically not the preferred initial agent post-cardiac arrest shock due to risk of tachyarrhythmias. Under other inotropic or vasopressor options. The optimal goal of therapy is not well established, but typically titrate to a map of more than 65 mm mercury, which is preferably more than 80 mm mercury to optimize the cerebral and endoral perfusion. Now the continuous IV infusion dosage is usual dose, it is from 5 to 20 microgram per kg per minute. In dopamine usage in bradycardia or AV block or symptomatic bradycardia, which is unresponsive to atropine. The usual dosage is IV continuous infusion is initial 5 microgram per kg per minute and increased by 5 microgram per kg per minute every 2 minutes until the desired effect. The maximum dose is 20 microgram per kg per minute. Coming to the pharmacokinetics of dopamine, onset is less than 5 minutes, duration is less than 10 minutes, half-life of dopamine is 2 minutes, and metabolism is by renal, hepatic, and plasma by monoamine oxidase. Coming to the adverse effects of dopamine, it will cause chest pain, hypotension in low doses, hypertension in high doses, ectopic beats, palpitation, nausea, vomiting, headache, tissue ischemia, and tachycardia. Dopamine infusion should be delivered into large central veins, otherwise it causes extensive tissue necrosis due to the extravasation through peripheral veins. Coming to the second catecholamine is epinephrine, that is adrenaline. It is an endogenous catecholamine released from the adrenal medulla. Actions: both alpha-1 and beta-adrenergic receptor action, it is beta-1 and beta-2, which leads to increase the heart rate, cardiac output, systemic vascular resistance, and blood pressure. Clinical uses important role in resuscitation of cardiac arrest, drug of choice for hemodynamic support in anaphylactic shock, also effective in septic shock and symptomatic bradycardia. Coming to the important action of epinephrine is first one is very drug of choice in anaphylaxis and other severe immediate hypersensitive reaction. That is IM administration in the anterolateral aspect of middle third of the thigh is preferred. And AL administration is essential to prevent progression to life-threatening manifestation. Usually the route is intramuscular. Dosage is 0.3 or 0.5 mg using the 1 mg per ml solution. Okay, and most of the patient responds to first or second dose of IM dosage. If inadequate response, additional measures should be instituted. Coming to intravenous or intraosseous route. In general, reserve the IV administration for patients who are unresponsive for multiple intramuscular administration. So only use intraosseous when intravenous access not readily available. Dosing is the same as the IV route. So basically, drug we can give by IM route of 0.3 or 0.5 mg. After giving multiple doses of IM, patient is not responding, then we can give via intravenous or intraosseous route. Continuous infusion by IV route is by initial 0.1 to 0.2 microgram per kg per minute. Administered with fluid resuscitation, and starting doses depend on severity of the anaphylaxis, and titrate every 2 to 3 minutes by 0.05 microgram per kg per minute to response. And the usual dosing range from 0.01 to 0.2 microgram per kg per minute. In slow IV bolus, only consider in impending cardiopulmonary arrest when continuous infusion of epinephrine is not immediately available. IV bolus administration may be associated with cardiac arrhythmias and cardiac ischemia. Initial 0.05 to 0.1 mg using the 0.1 mg per ml solution. To get a 0.1 mg per ml solution, we dilute 10 ml of NS with 1 mg of adrenaline and administer every 1 to 10 minutes and may repeat once after 3 minutes if patient remains unresponsive to initial dose. If inadequate response, additional measures should be instituted like IV fluids and continuous IV epinephrine infusion. Patient develops cardiopulmonary arrest, use higher intravenous or intraosseous bolus dose, that is 1 mg. Coming to the second use of epinephrine in septic shock and other vasodilatory shock states. Consider an adjunctive use when gold map not achieved with initial vasopresors or need for inotrope therapy. In general, maintain a gold map of more than 65 mm mercury and consider use of patient is in shock during or after fluid resuscitation. Coming to the IV dosage, there are two types of dosing system. One is weight-based dosing system and non-weight-based dosing system. In weight-based dosing system, IV initial 0.01 to 0.2 microgram per kg per minute and titrate to a gold map or end-organ perfusion. Usual dose range from 0.01 to 0.5 microgram per kg per minute and maximum dose range for refractory shock is 0.5 to 2 microgram per kg per minute. Next one in hypotension or shock caused by cardiogenic shock. Typically not the preferred initial agent cardiogenic shock. Consider other options. The optimal goal of therapy is not well established, but typically titrate to maintain end-organ perfusion. Continuous infusion dosage, it is weight-based dosing. Usual dose range from 0.01 to 0.5 microgram per kg per minute and titrate based to clinical endpoint. Coming to sudden cardiac arrest due to asystole, pulseless electrical activity, ventricular fibrillation, or pulseless ventricular tachycardia, you can go through IV or intraosseous route. It is 1 mg every 3 to 5 minutes until the return of only circulation. You can also use through endotracheal 2, that is 2 to 2.5 mg every 3 to 5 minutes until intravenous or intraosseous access established or return of spontaneous circulation. Before administration, dilute in 5 to 10 ml NS with soil water using 1 mg dermal solution and use hyperventilation or manual ventilation after administration. Coming to post-cardiac arrest shock. Optimal goal of therapy is not well established, but typically titrate to mean arterial blood pressure more than 65 millimeter mercury. Coming to the dosage, in continuous infusion dosage, IV usual dosage range from 0.01 to 1 microgram per kg per minute and titrate based on clinical endpoint. Maximum dose for refractory shock is 2 microgram per kg per minute. Next one is in bradycardia or AV block or symptomatic, which are unresponsive to atropine. We can use epinephrine. The dosage is 2 to 10 microgram per minute. Then usual dose range from 8 to 40 microgram per minute and titrate to the side effect. Into the pharmacokinetics, onset of action is 1 to 2 minutes and duration of action is 2 to 10 minutes. Half-life is less than 5 minutes. It is metabolism by hepatic and other tissues, and hepatic metabolism is by monoamine oxidase and catechol-methyl transferase. Next question is through urine. Adverse effects of epinephrine can increase the risk of unwanted cardiac stimulation than other catecholamine drugs. Angina, palpitation, arrhythmias, hypertension, tachycardia, headache, vomiting, and pulmonary edema. Then the important one is norepinephrine. It is a endogenous catecholamine and action of norepinephrine. The principal action is alpha receptor mediated peripheral vasoconstriction and increased blood pressure. As beta adrenergic receptor action, beta 1 is more than beta 2. So inotropic stimulation of the heart and coronary vasodilation. Indication of norepinephrine in acute hypotension and shock, drug of choice, and initial vasopressor of choice in severe sepsis and septic shock, refractory to adequate fluid suspension. Coming to indications of norepinephrine, the most important one is septic shock and other vasodilatory shock states. In general, used to maintain a gold map of more than 65 millimeter mercury and consider use if patient is in shock or was hyperperfusion during or after fluid suspension. Coming to the dosage, continuous infusion dosage IV route. Initial 0.05 to 0.15 microgram per kg per minute and titrate to a gold map. Usual dose range from 0.025 to 1 microgram per kg per minute and maximum dose range for refractory shock is 1 to 3.3 microgram per kg per minute. While available data describe a wide range of initial dosing provides reasonable starting point for most of the patients. Coming to cardiogenic shock, optimal goal of therapy is not well established, but typically titrate to maintain endurance perfusion. Coming to the dosage, in IV route, initial 0.05 microgram per kg minute and titrate based on clinical endpoint, that is beat map of more than 65 millimeter mercury and endurance perfusion. Usual dose range from 0.05 to 0.4 microgram per kg per minute. Then coming to post-cardiac arrest shock, the dosage is initial 0.05 to 0.15 microgram per kg per minute and titrate based clinical endpoints. And usual dose range from 0.05 to 1 microgram per kg per minute and maximum dose range for refractory shock is 1 to 3.3 microgram per kg per minute. Coming to the pharmacokinetics, its onset of action is very rapid. Duration of action is 1 to 2 minutes. Half-life is 1 to 2 minutes. Metabolism is monoamine oxidase and catechol-methyl transferase. Next question is through urine. Come to the adverse effects. Norepinephrine adverse effects includes bradycardia, peripheral ischemia, arrhythmia, hypertension, headache, vomiting, and cardiac arrest. Next one is phenylephrine. It is a potent vasoconstrictor and synthetic non-catecholamine. Action of phenylephrine, selective alpha receptor agonist, causes increased systemic vascular resistance and elevates systolic and diastolic blood pressure through arterial vasoconstriction. Indications are hypotension and vascular failure shock and not recommended septic shock. Phenylephrine we can use in hypotension or shock, but it was not recommended for septic shock except in the following circumstances. One is when norepinephrine is associated with serious arrhythmias. Then the next one is when cardiac output is known to be high and BP persistently is low. Or we can use it as a salvage therapy when the combination of vasopressors or inotropic agents and low dose of vasopressors fail to achieve a target MAP, which is more than 65 millimeter mercury. In these three conditions, we can use phenylephrine in hypotension or shock. Then in septic shock and other vascular shock, dosages is continuous infusion by IV, which was 0.5 to 2 microgram per kg per minute and titrated desired MAP. Usual dose range from 0.25 to 0.5 microgram per kg per minute. Then in cardiogenic shock, for initial vasoactive management of cardiogenic shock due to aortic stenosis, mitral stenosis, or hypertrophic cardiomyopathy with left ventricular outflow tract obstruction, dosage is 0.1 to 10 microgram kg per minute and titrated inclined. Next one we can use in priapism, that is acute ischemia. The optimal dosing frequency method of administration has not been established. We can use the route by intracavernous injections. It is 100 to 500 microgram every 5 minutes or greater as needed for up to 1 hour. If used with aspiration or irrigation, then aspiration should be performed before administration of phenylephrine. Coming to the pharmacokinetics, onset of action is immediate, duration of action is 15 to 20 minutes, half-life is alpha phase and beta phase. In alpha phase is 5 minutes and terminal phase is 2 to 3 hours. And metabolism is by IV, hepatic by oxidative deamination. It undergoes sulfation and some glucuronation. Excretion is through urine. Coming to the adverse effects of phenylephrine, hypertension, low cardiac output, reflex bradycardia, and arrhythmias. It also lead to renal and mesenteric and myocardial and peripheral ischemia. Coming to the next drug is vasopressin. Vasopressin is an endogenous noradrenergic vasopressor. Stimulates the V1 receptors in vascular smooth muscles, causing direct peripheral vasoconstriction, increasing systemic vascular resistance and blood pressure, and it improves cerebral and cardiac perfusion. It does not exhibit inotropic or chronotropic effects on the heart and can cause a decrease in heart rate and cardiac output. Vasopressin also acts on V2 receptors in the kidney, causing an antidiuretic effect. Coming to the indication, vasopressin we can use in septic shock and other vascular entry shock states. Considered as an adjunctive use when goal mean arterial pressure not achieved with initial catecholamines like vasopressors, or to decrease the catecholamine vasopressin dosage requirement. In general, maintain a goal map of 65 mm mercury. Consider use if patient is in shock plus hyperperfusion during or after fluid resuscitation. In shock due to sepsis, we can use a continuous infusion. The IV dosage is 0.03 units per minute added to the norepinephrine as a fixed dose. Usual dose range from 0.01 to 0.04 units per minute. Dose which is more than 0.04 units per minute should be reserved for salvage therapy due to potential risk of ischemic complications. And discontinuation of septic shock. The multiple studies describe clinically significant hypotension when vasopressin is discontinued prior to the norepinephrine. And this discontinued therapy, consider slowly tapering by 0.01 units per minute every 30 to 60 minutes to reduce the risk of hypotension and monitor the MAP when discontinuing vasopressin. And other use in pulseless arrest, ventricular fibrillation, and ventricular tachycardia. Limited data available in infants and children and adolescents. We can use IV route. The dosage is 0.04 units per kg. It's a single dose after judicial resuscitation methods. At least 2 doses of epinephrine have been administered. Coming to the pharmacokinetics, onset is rapid, duration less than 20 minutes, half-life of less than 20 minutes, metabolism of vasopressin by hepatic and renal route, excretion is through urine. Coming to the adverse effects of vasopressin, it causes diaphoresis, nausea, vomiting, headache, urticaria, arrhythmias, centric and peripheral ischemia, chest pain, MI, bronchoconstriction, and cardiac arrest. Next one is angiotensin 2. Angiotensin 2 is a octapeptide hormone compound offered in angiotensin-aldosterone system that raises the blood pressure by stimulating the vasoconstriction and release of aldosterone. Randomized trial demonstrated that angiotensin 2 increases the blood pressure when given to a patient in septic or distributed shock who remain hypotensive despite fluid resuscitation and norepinephrine. 70% of the angiotensin group compared to 23% of the placebo group reached target blood pressure over 3 hours. However, there was no mortality benefit. Coming to the indication, in septic shock or the vasodilatory shock state, continuous IV infusion dosage is initial 10 to 20 nanogram per kg per minute and titrate dose up to 10 to 15 nanogram per kg per minute every 5 minutes based on the cold map. Once shock has sufficiently improved, decrease the dose by less than or equal to 50 nanogram per kg per minute every 5 to 15 minutes based on response. The maximum initial dose is 80 nanogram per kg per minute during the first 3 hours of treatment, and the maximum minimum dose is 40 nanogram per kg per minute. Coming to the pharmacokinetics, onset of action is 5 minutes with infusion and duration up to 3 hours, half-life of less than 1 minute. It is metabolized by enzymes found in the plasma, RBC, kidney, liver, and lungs. Coming to the adverse effects, it causes thromboembolic events, thrombocytopenia, tachycardia, fungal infection, and acidosis. Next, we are going to discuss inotropes. First one is dobutamine. Dobutamine is a synthetic dopamine analog with potent inotropic and mild vasodilatory and chronotropic effects. It competitively binds and stimulates the alpha and beta receptors, resulting in increased contractility and heart rate with neutral effect for possible decreased blood pressure. Beta-1 receptor mediated action produces a increase in heart rate and stroke volume, while beta-2 receptor mediated action produces peripheral vasodilatation. Coming to the action, in inotropic support in patients with shock, example sepsis, who fail to meet the hemodynamic goals with the vasopressor therapy, dobutamine may be added to vasopressor therapy if there is continued hypoperfusion despite volume resuscitation. Coming to the continuous IV route, initial 2 to 5 microgram per kg minute titrate versus clinical endpoint. Usual dose range from 2 to 10 microgram per kg per minute. However, dosage as low of 0.5 microgram per kg per minute have been used in less severe cardiac decompensation, and maximum dose is 20 microgram per kg per minute. Coming to the pharmacokinetics, onset of action is 1 to 10 minutes, peak is maximum of 10 to 20 minutes, and half-life is 2 minutes. Metabolized by tissues hepatic to inactive metabolites. Excretion is through urine. Coming to the adverse effects, includes hypertension, tachyarrhythmias, headache, angina, and hypokalemia. Coming to the next drug is milrinone. It is an inotrope with vasodilator properties that selectively inhibits the phosphodiesterase type 3 enzyme, resulting in the inhibition of cyclic adenosine monophosphate breakdown in the myocardial and vascular smooth muscle cells. Increased cyclic adenosine monophosphate level result in increased cardiac contractility, peripheral arterial and venous vasodilatation, and increased cardiac output and reduce the systemic vascular resistance. Coming to the indications, in acute decompensated heart failure, may consider for short-term use in patients with low cardiac index and hypertension or end-organ hyperperfusion. It can use this IV continuous infusion. The dosage is initial 0.1252 to 0.25 microgram per kg per minute and titrate with clinical endpoint. and the usual dosage range from 0.125 to 0.75 microgram per kg per minute. Initial IV bolus loading dose are not recommended due to complication of hypertension. Coming to the pharmacokinetics, onset is 5 to 15 minutes, half-life is 2.3 to 2.4 hours, and metabolism is by hepatic and excretion through urine. Adverse effects of midraners causes ventricular and supraventricular arrhythmias, hypotension, angina, and headache. Thank you.